Assalamu alaikum and
عليكم
good
السلام.
morning, dear ladies and gentlemen. And I think you all agree that papillary thyroid carcinoma or well-differentiated carcinoma is the most common type of thyroid malignancies, and the incidence is rising in the last few years, making thyroid carcinoma the third most common malignancy after breast and colorectal cancer. And unfortunately, almost one-fourth of patients with uh, well-differentiated thyroid carcinoma, they will develop metastasis, and one-third of those metastatic will be radioactive and refractory. That's making almost 70% of the total number of thyroid carcinoma. They are radioactive and refractory. And if you're looking for the prognosis of those group of patients, so from the literatures, and if you're looking for the control group where they received placebo from a phase 3 trial, the median survival for patients with radioactive and refractory thyroid carcinoma is 2.5 years, maximum 3.5 years, while the median progression-free survival from 3 to 5 months. So we have a very poor prognosis. And if you put in the context of the 10-year survival for patients, those are still iodine sensitive. So 92% of the patients, they might survive 10 years. For those with the iodine refractory, almost 10%, they might survive for 10 years. So there is unmet need for this group of patients. But before going into the management of this group of patients, we need to have an agreement. What is the definition of radioactive and refractory? Because what I see there is some gap in the definition when we label the patient as radioactive refractory. So to make it easy, if the disease does not taking up iodine at a known site of metastatic disease. So here's an example: if patients with whole body iodine scan, which is as a negative, there is no in uptake, while in other scans such as PET scan, there is an distant metastasis. That means that tumor not picking up iodine, and this is one of the examples of radioactive iodine refractory. The second example that if the patient already they have whole body iodine scan where the tumor is still growing, or there is some region having uptake and others there is no uptake, and this should be by different scans or different modality. Also, it is considered as a radioactive iodine refractory. Other patients, if they have a disease which grow within 1 year from the last dose of radioactive refractory, that means also they are radioactive refractory. The fourth point, which is in a debate between many of the neuronuclear medicine and we might have a discussion for this. If the cumulative dose of radioactive refractory reach to 600 millicurie, some other centers they might go up to 900 and even above. But most of the literature they cap at 600 millicurie. So if your patient under this categories, so there is no place for radioactive iodine therapy, and they consider radioactive iodine refractory. With more understanding of the thyroid carcinoma, and I think Dr. Sarbar, he had a good job in explaining the pathology. So with more understanding of the genetics of the thyroid carcinoma, you can see that papillary carcinoma, which is the most common type, 70% of the patients they have underlying mutations. Some of these mutations are driver mutations, such as PRAF. In up to 50% of the patient population, they have PRAF mutation. PET alterations with a fusion or a mutation from 10 to 20%, and NTRK also around 5%, making thyroid cancer one of the tumors can be treated by a targeted therapy. So how we target this? We have two types of cells: the tumor cells, where if we tackle the proliferation of the cells, we might control the disease, and also knowing that the thyroid cancer are highly vascular tumors. So by tackling the angiogenesis, and the endothelial cells also might control the disease. And here, where we have a lot of trials addressing the efficacy of the multi-target kinase inhibitors targeting the tumor cells and the endothelial cells to control the disease. And the most common and approved multi-target tyrosine kinase inhibitors, the first in this class, sorafenib, which is targeting the vascular growth factor receptors and lipid degradation growth factor receptors, which is both are involved in angiogenesis. BRAF, KIT, and RET also involved in the cell proliferation. The second drug was lenvatinib, which, as you see, also targeting both the cell proliferation and angiogenesis. The most recently multi-target tyrosine kinase inhibitor, the cabozantinib, also has been approved in this indication. So this approval came from a phase 3 trial, and this is a decision trial for sorafenib. So to make it simple, decision trial included patients with local advanced or metastatic radioactive iodine refractory DTC. They are treatment naive. So randomized to sorafenib, which is 400 milligrams twice daily, or placebo. In this trial, looking for a primary endpoint with the progression-free survival, and second endpoint is overall survival. The trial was significantly positive, and adding sorafenib, it extended the median progression-free survival from 5.8 months to 10.8 months. So 5 months gain in progression-free survival, with almost 41% reduction in the risk of progression in favor of the sorafenib. And based on this trial, sorafenib is considered as a standard of care for this group of patients. But there is some limitation for the sorafenib, which is the response rate. If you're looking for the response rate, it's only 12%, where the most of the patients, they have stable disease in around 42%. So if you have a bulky disease, larger tumor, probably sorafenib will not be the best tumor. But if the small metastasis, so probably just to keep it as stable disease, it might be of benefit. And this comes with the price. So especially if you know that there's no overall survival benefit from the giving sorafenib. And the reason behind that, when the decision trial being randomized, there was no any standard of care. We know that the chemotherapy has no role in cervical carcinoma. So almost 75% of the patients in the placebo arm, they cross to the sorafenib arm. So we're expecting this trial will lose the overall survival, and this is what happened. But again, it comes with a price, which is a toxicity, and I think Dr. Kaki Rasool, he mentioned the toxicity of the sorafenib, which is mainly hand-foot skin reaction, diarrhea, alopecia, rash, fatigue, weight loss, and hypertension. All these should be in consideration when prescribing sorafenib for our patients. So with the caveat of low response rate and some toxicity, so we have to balance between the efficacy and toxicity and to maintain the patient quality of life. The second drug, which is lenvatinib, and again, lenvatinib is a multi-target kinase inhibitor, and this is the SELECT trial, which is the phase 3 trial. It's a little bit different from the previous trial because in this trial, the included patients those having prior tyrosine kinase inhibitors, which is almost 20% of patient population received prior sorafenib. So 1/4 of those group of patients, they received a treatment before, so that's like a second line, but the 3/4 are treatment naive. I mean, never received any tyrosine kinase inhibitor. So it's 2-to-1 randomization, lenvatinib with a standard dose 24 milligram daily versus only placebo. And the primary endpoint this trial is progression-free survival, where the overall survival, response rate, and safety are secondary endpoints. In this trial, they allowed the patient in the control arm to cross over to lenvatinib at time of progression. And you can see this fantastic separation in the curves where the lenvatinib extended the median progression-free survival from the 3.6 months in the placebo group to 18.3 months for the lenvatinib, with the almost 15 months difference or gain in the median progression-free survival, which never happened before. What is unique about lenvatinib is the response rate. And this response rate is very significant, talking about 65% of the patients, they achieve some sort of response. So reducing the size of tumor is significant in this group of patients, no matter if the patients are treatment naive, no prior VEGF, or even if they receive prior tyrosine kinase inhibitor, still will have significant response rate is 62%, and still significant improvement in median progression-free survival. So lenvatinib giving higher response rate and longer median progression-free survival compared to the placebo. But because of 83% of the patients in the placebo arm, they crossed to lenvatinib at time of progression, so there is no overall survival benefit. But again, it's not a drug with a free toxicity. We have also a significant toxicity, mainly hypertension, diarrhea, fatigue, loss of appetite. Some patients, they might have nausea, vomiting, or weight loss. So also we need to adjust the dose sometimes for our patients to be maintained on this very effective drug. But the question is, lenvatinib and sorafenib are the first-line treatment options. So what is beyond the first-line treatment? So we have a multi-tyrosine kinase inhibitor, which is the cabozantinib. And this is the COSMIC 311 trial. It's a phase 3 trial, including patients those previously treated. Sorafenib, some of the patients received lenvatinib, and some patients received both sorafenib and lenvatinib. So beyond progression, they randomize the patient to cabozantinib, which is 60 milligram once daily, or placebo. It's a 2-to-1 randomization, and they are also looking at the primary endpoint for the progression-free survival and response rate. And here, just to highlight that the baseline patient characteristic and the patient dose previously treated. So almost 37% received sorafenib, 40% lenvatinib, and 1/4 of the patients received both sorafenib and lenvatinib. So they are heavily pre-treated patients. And you can see how cabozantinib significantly improved the median progression-free survival. So 1.9 months for the placebo group to 11 months for the cabozantinib group, with the 78% reduction in the risk of progression or death in favor of cabozantinib, and this is very significant, has a ratio of 0.22. Response rate, it's 15%, so it's not that great response rate, but knowing that sorafenib in the first line only response rate 12%, and these groups which are heavily pretreated, so having 15% response rate, it's considered significant, especially we don't have in the past any option for those group of patients. But almost 70% of the patients will have a stable disease.
Dr. Emad, you have 1 minute.
And again, it comes with a price of toxicity. Almost patients need dose modification in 67%. The most common toxicity, hand-foot skin reaction, diarrhea, hypertension, and loss of appetite. Then we have a driver mutation that I mentioned before, and luckily we have target therapy. So NTRK fusion in the thyroid carcinoma is around 5% of the patients. We have 2 drugs approved in this indication. Darovasertib, it's an NTRK inhibitor from a phase 2 basket trial. They're looking for the response rate, which is quite significant. 79% of the patients they have a response, and the median overall survival for this group of patients 44 months. Median progression-free survival almost 2.5 years. And if the patient responds, they will stay on the response for almost 3 years. So quite significant outcome from lorlatinib in this group of patients. The other drug, which is entrectinib, is again another TRK inhibitor, but also TROS1 and ALK inhibitor. In this basket trial, also showing a 57% response rate, with almost 21 months median overall survival and median progression-free survival 11 months. If patient responding, the median duration of response around 10 months. So, which is another drug which is effective in this group of patients. So, if the patient they have NTRK fusion, so we have 2 drugs approved in this indication. RIT inhibitor, which is another class of medication, we know that RIT fusion is around 10 to 20% in the patient with differential carcinoma, and RIT mutation is more common in medullary thyroid carcinoma in patients with MIN2. The prevalence around 90%, and in sporadic medullary thyroid carcinoma is 6%. So we have 2 drugs, silpercatinib, which is a RIT inhibitor from the phase 2 trial, for patients those are treatment naive RIT fusion. So we have very significant response rate, 79% of the patients they got response, and the median progression-free survival 1 year in 64% of those patient population. And based on this trial, silpercatinib also approved in the thyroid carcinoma as a treatment option for patients with RIT fusion. We have persilotinib, which is another RIT inhibitor, and this is an R trial for patients with the RIT fusion positive DTC. Small number of patients, but again, we have very significant response rate with the 91% response rate, and that's quite significant. And again, based on this trial, persilotinib approved as a treatment option for RIT fusion and positive carcinoma. Last but not least, the BRAF inhibitor and both dapagliflozin and trametinib, which is MEK inhibitor and BRAF inhibitor, been approved based on a basket trial for patients with BRAF V600E mutations. But what in the future to combine these two drugs, dapagliflozin and trametinib, with iodine therapy, making the tumor more radioactive and sensitive. And you can see here where when you're adding dapagliflozin, trametinib, and iodine therapy, you can see that there is significant uptake in the iodine therapy and decrease in the tumor marker. So the take-home message, the survival in patients with the progressive radioactive iodine DTC is poor. The median survival range from 2.5 years, maximum 3.5 years. We have two drugs in the first line, lenvatinib and sorafenib, considered standard of care for progressive radioactive iodine refractory DTC. Both drugs significantly improve progression-free survival with no overall survival benefit, and this is due to the crossover in both drugs. How to choose between the two drugs? Lenvatinib significantly improved the response rate, which is around 65%, considered preferred treatment option, especially if you have bulky progressive disease and if the patient are symptomatic. But also the toxicity profile of each drug are unique, with more hypertension with lenvatinib and more hand foot skin reaction with the sorafenib. So we might choose also based on the skin toxicity. While cabozantinib is now considered a standard of care in second line or third line, based on the improvement in progression-free survival versus placebo in patients with radioactive refractory those failed prior tyrosine kinase inhibitors, with a median progression-free survival almost 11 months. And this improvement was in PFS was across subgroup or all subgroup of patients, whether the patient received lenvatinib before or sorafenib or even both. And last but not least, the RIT inhibitors now are considered standard of care for advanced or metastatic RIT fusion post-steroid cancer who require systemic therapy and who are radioactive iodine refractory. And with that, I will thank you for listening. I'll be happy to take any questions in the Q&A session. Thank you.